Hi everyone, it's Nick with the STARS program. This video is for my dispatchers. And so this is part of a series for how to use our application, but this video really is more of a why. And as we have started to implement in my dispatch agencies, some of their leaders have rightfully said, what is the advantage or why should we do this? How can we help? And so, we kind of realized that we have spent a lot of time as the STARS program out talking to EMS providers and explaining to them why we think this improves emergency care for some of our high-risk pediatric patients. And in fairness to our dispatch agencies, they haven't always gotten to hear that same message from us. And so I thought this was a good opportunity for us to record, a video of us talking through the advantages it brings for our kiddos. So obviously here at the STARS program, our purpose is to create custom-made care plans for pediatric patients so that we can follow them in the pre-hospital environment and provide just-in-time needed information for them in emergencies. And sometimes people still ask me, why. They say, they're very nice when they ask this, but they say, in emergency medicine we run this huge gamut of calls, and pediatrics is a fairly small portion of that, and special needs pediatrics is an even smaller slice of the pie. And I have a couple of answers for that. So first of all, 0 to 17 years of age special healthcare needs patients is one of the fastest growing patient populations in the U.S. We are saving kids from pathologies that previously they probably would have passed away from. We are doing that through amazing care, through amazing meds, and through amazing technology. The complication of that is that the kids are getting increasingly complex and can really be a challenge to a lot of healthcare providers. And we haven't always been adequately trained on what to do for these kids, as we'll kind of discuss in some future slides here. The downside of this is that there have been some very negative consequences in the field. And we really think that with information and education, we can improve those outcomes. This slide has some examples of that patient growth, patient population growth. You can see 2017 to 2018, Cardinal Glennon had a 40% increase in the number of tracheostomy patients. And we have had similar numbers reported to us from St. Louis Children's and from Mercy as well. One of the things that happens is, as these kids are getting discharged home, both in the paperwork and in the final discharge sessions with the parents, they're told, and if you have any problems, call 911. They'll know what to do. And the hard part for us as pre-hospital providers is we know that we were not always trained on what to do in all these situations. And that's why we need a system to provide us that information both prior to us getting to that call and also for how we navigate that emergency. These are some of the challenges we see in the pre-hospital environment for treating our complex needs patients. So, our EMS agencies might be limited to a closest hospital, and sometimes that closest hospital is not that much more well prepared for what to do for some of these syndromes. As we kind of talked about, some of these kids unfortunately previously passed away from these diseases. They are pathologies where patients have not always lived to the age of 18. It's not really well known in adult world. And so sometimes the hospital can be every bit as challenged as our pre-hospital providers. And so a lot of times we see other challenges: misinterpretation of assessment finding, inability to find a DNR or follow a DNR. Specialty care letters and emergency information forms are something we'll talk about in the next couple of slides, but these were devices and letters that were meant to provide this information to EMS, and we'll talk about why they failed. And then, there's other things we see, failures that we see, is that patients might not receive life-saving medications or treatments just in time for their emergency. And I'll kind of demonstrate, how we all have a lack of foundational knowledge on a lot of these specialties. So these are two examples of some forms that previously were sent out with patients. And so, the healthcare system has known for a while that this has been a challenge, getting this information about these atypical patients, these high-risk patients, out to pre-hospital providers. And so they came up in the 90s. There was a system kind of developed of we'll write all the information down on an emergency information form. If we have specialty orders that need to be given, it'll be written in letters. will send that information home with the parents. And when EMS arrives at their house for the emergency, the parents can hand the information to the medics and they will be able to appropriately treat this patient. And, it's all great information, but the delivery method is suspect at best, right? It's because you and I, as pre-hospital providers, all immediately see the problem of this. We are meant to show up at 3 in the morning trying to rub the sleep out of our eyes. We're going to see a blue kid on a couch and we're going to get handed 15 sheets of paper, half of which are handwritten. And I'm supposed to read this right then and there and then know what to do. And unfortunately, in reality, what's going to happen is I'm going to say, somebody go throw this paperwork in the truck. I'm going to take care of this blue kid. And then hopefully I'll get a chance to read that on the way to the hospital. Like I said, the information was great, but the delivery method is a challenge. All right, and so that kind of brings us to why STARS. And so the forms, all these different medical agencies have always agreed, like, this is what we need to do so that EMS can be aware of the pediatric patients. But unfortunately, just simply telling EMS agencies that they have these kids in their area has not worked up until this point. And so we have seen those poor outcomes, including death and neurological devastation to our patients. And this is why we think those traditional paper plans fail. Unfortunately, they were sometimes written by people who have no idea what EMS can or cannot do. It's super easy for paper to go missing, for binders to go missing. They're very hard to keep updated. So these kids, a lot of them are very dynamic and they change meds quickly and they change treatments quickly. And it doesn't take long for that information sitting there on that sheet of paper to be out of date. And then there have always been these concerns. One of the traditional ways or traditional things that happen to these paper forms is they got put on a bulletin board inside the ambulance house somewhere. And on a long enough timeline, somebody's like, I don't think this should be up here. And they take it down, even though that information was meant to be for them and to be available to their whole agency. And so sometimes that information goes missing. The other thing, it's just a sheet of paper, right? And so there needs to be education provided. I could have a rocket engineer send me a schematic and say, here, this is the plan has to be followed. And I'm going to be like, I have no idea. I don't remember how to do calculus and I don't know what any of this math means. There has to be more than just a paper system in place to try and take care of these kids. We need education. We need other components. And so sometimes we also haven't, traditionally these paper systems have not included the EMS physicians. And so they didn't get a chance to say like, oh, well, that kid needs this certain drug. My crews don't even carry that drug. Should we carry it or should we ask if there's something else we can do, right? And so we are leaving out major pieces of the puzzle. Without those extra steps, then there's questions, will the specialty letters be followed? Does my EMS physician who governs or who regulates my license, does he even want me to follow these letters and orders that are just left for me at someone's house? Just a lot of challenges are left by the paper system. And so what we kind of have learned as time has gone on with our program is that this is a challenge. The healthcare system knows it's a challenge, but nobody's solved it yet. How do we connect hospital clinics to emergency departments to EMS and to dispatch and to pre-hospital? How do we put this all together? And so as we have built this program, we've come more and more to the model of we run the plans out of the children's hospital and then we share them out with our EMS agencies, and we really have to find that way to provide the information to them prior to the emergency and at the time of the emergency. What we really have learned over time is that there is no easy button. Trust us, we keep looking for one. We keep thinking like, oh, if we just came up with the technology, that would fix it. And if we just came up with this job role, that would fix it. And what we have learned is it takes a team of people working on this project to get better outcomes for these pediatric patients. And so one component we have learned is that while there is no easy button for the system at large, EMS has to have an easy button at the time of the emergency. They have to have quick access to this information, and the information needs to be up to date and accurate. All right. right. I do sometimes still always get asked, for your star, this big star system you guys are working on, who is a star, who belongs. And I could read this list to you, but I think the more important way to look at this list is a patient who qualifies to be as a current star is somebody who their treatment deviates from our typical treatment patterns. So, we are taught to very much follow these algorithms, and that's to make sure we don't miss anything and that we take appropriate care of our patients. Unfortunately, those algorithms are not accurate for all patients and their medical history. And not only you might not help that patient, in some cases you might hurt them if you were to blindly follow your algorithms. And so we really focus on those kids who deviate from the ABCs that we're taught to follow. And then the other group of kids who gets in are just the really complex kids where you could show up and you would look at that kid and you'd be like, oh, this kid is sick today. But is it a neuro problem? Is it a GI problem? Is it a cardiac problem? And we kind of provide some guidance on which way to jump on those kiddos, which way you should try to solve their medical emergency that day. We take the referrals for those patients. The plans, as I said, are now written by paramedics who work at the children's hospitals. We get double checked on our work at our hospitals by the specialist. So we have medical directors for our programs who review the forms, or if it's a really complex case, we'll go to the actual specialist involved for that kid. And so they make sure that our plan is appropriate for the kid, and then we still include the EMS medical directors. And any plan you see live in the system had to be approved by both of these medical directors. And that's what is allowing us to essentially write these custom-made protocols that are specific to these kiddos. And then, as I mentioned before, the final component of this is that we have to have live training and education regarding these kids, and that's what we go out to provide to our EMS agencies as often as we can. Unfortunately, currently over Zoom more often than in person, but hopefully we'll get back to more in person. So we do have the program. It's up over 700 stars, including over 580 in the active electronic application. We continue to find new specialties at kiddos, and we're continuing to grow expansively. All right. So that brings me to discussing the application. So our program started out in paper on binders, and we discovered all of those same problems that we've already discussed. And what we have ultimately evolved to is having all the kids centralized back into an electronic database that is accessible by everyone, and that helps us solve some of those problems we mentioned. It solves version control. I can go in on the application right now and I can edit information for a kiddo. I can hit save, and in 10 seconds when an EMS crew responds to that call, they will have the most up-to-date information. It also gives you access to all stars. One of our previous problems was, you could be as good as you wanted to be as a care provider for those kids in your binder. And you as dispatchers, you could know all the kids that lived in the area for your EMS agencies. But the second that a kid drove across the border from the next county over and had an emergency in your district, you did not have the ability to share that information with anybody to access their STARS plan. Well, now through the electronic application, we have access to all the stars, and you can send plans to all of your providers. We have the attachments. So if there's a DNR or a specialty care letter, that can be attached for that kiddo and sent to the crews. And then it really simplifies some of the other components, such as the medical director approval. And then we eventually obtained, we always knew the gold standard was we wanted to be able to get the plans to the EMS crews password free for an emergency. We had gotten lots of feedback over the years that people thought, oh, the application is cool, we like accessing the information, but we have failures whenever it's actually time to get in the truck and go to that 911 call. So they would have a password failure or a login failure, and there was a lot of frustration there, as you can imagine, as there is with any of our programs that don't work appropriately when we're toned out to the call. And so we wanted to be able to eliminate that password step. And so what we came up with was the ability to dispatch, and I'm going to use air quotes. You can't see me doing it because I am not a dispatcher. I'm not doing your role as a dispatcher. But we came up with the ability to send the plans to the crews on their way to that call. And so quite simply, all it is that our dispatch agencies just have access to the application. They have the ability to pull up any one of these STARS numbers and send the plan, and then they select the EMS agency that is going to that call, and they can just send the plan to them. As our program moves forward, a big part of what we're working on, we want to further include EMS and dispatch and the whole pre-hospital care team. This is kind of a major shift for everybody, right? We're going from being reactive to proactive as much as possible on behalf of these patients, and the idea that we need to spread the information, get the education out there, and have it available at the time we need it. And then we'll also, that's starting to spread into other components of pre-hospital care, such as community paramedicine and telemedicine, just because what's better than doing well at emergency is just preventing one before it ever happens. So at the end of the day, what we're really asking and we're really thankful for is just getting help on the calls, getting better outcomes for some of these kids, and getting the information to who needs it in time to treat that kiddo. We certainly encourage the use of STARS in training wherever that is applicable for you at your agency, but we think that we have a ready-made group of patients who need our system and need our services. And so we tell the parents whenever we put the kid in and we have them sign the HIPAA waiver to be in our program, we're going to tell dispatch about your kid. We're going to tell EMS about your kid. We're going to train on your kid. We are going to discuss their care so that we avoid those negative outcomes, so that we can share this information with everybody. And then obviously our PR game is currently slightly hindered by the current pandemic. But as that eases over time, certainly we always encourage, as long as that family is willing, PR and meeting those kids in non-emergency situations. You are doing something above and beyond for your community, and we really encourage you to share that with your constituents. So the video that immediately follows this kind of demonstrates that more, how to log into the application and use it. I hope this kind of help explain why we do what we do, and how you can participate and be part of our program as we try to change this part of the pre-hospital care system. Thank you very much for your time, and please be safe out there.